to kind of have an unofficial network of like-minded thinkers. I will tell everybody here that Woodland Healthcare would really wishes someone was graduating this spring, and I do too, because my psychiatry practice is full up. The only thing that's kind of kept me not too bad is the recession has been so bad. So many people have lost their insurance, they stopped coming. I could, in a flash, stop seeing family practice and have an entirely full psychiatry practice. I don't really want to do that. There's something really spiritually refreshing for me to see a kid with an ear infection, or to do a path and pelvic on somebody, somebody who's normal, healthy, somebody who's can take responsibility for their care, who's concerned about their diabetes, managing it well. All that is, it works for me. It's also, I will tell you, primary care is a huge challenge. And one of the things that I found difficult in going to this relatively small setting is that I was asked to do stuff that, heck, I'd never seen in residency. Or a quantity of stuff that nothing like what I'd seen in residency, like simple little stuff. The bread and butter somehow or other doesn't come to our family practice clinic.
What do you mean?
Huh?
What do you mean?
Lacerations,
No.
acute injuries. Do you have that in internal medicine clinic?
Not lacerations, no.
Lacerations,
They
fractures.
go to the ER or urgent care.
I know. We get them. Fractures. I'm still terrified of fractures.
Really?
Yeah.
Wow.
That I'm terrified, or that we get them all?
We get fractures at the primary care center, but it's rare we'll get like lacerations or acute injuries, because they all go to the emergency room.
No, we get them.
Wow.
We get them, and I didn't feel entirely prepared for all that, though. One of the other nice things about a multi-specialty and a group practice in general is I'm not designed to be a cowboy out there in a rural area all by myself. There's lots of people that ask questions, and I've done that.
And that's what the other specialists in your group rely on you for the same exact
That's right.
reason.
So I had a kid come into urgent care, extended hours clinic, and he had this hematoma in his auricle. I've never dreamed of an auricular hematoma, and I called there's no ENT on call, so it's 7:30, so I paged him anyway, and he says, no, you shouldn't be expected to do that in clinic, and do a referral, and so he was seen the next 2 days or something. Right?
Do you think there are other parts of the country
Where what?
where there is creativity?
I hope so.
Well, actually, you're on this STAR committee thing with the CPE, California Psychiatric Association. And what's your impression? Do you see that there's a lot more interest in integration, even with psychiatrists? It seems like. Do you see that as well?
I do. There's that, and I also sit on the Council for Healthcare Systems and Financing with the American Psychiatric Association. That's something I started as a fellow of the VMS Fellowship, and I've stayed on. And we've been talking about the medical home and how do we use the medical home for the severely mentally ill and community mental health center, and what is our integration in the primary care clinic. And the impression I have is that it's the psychiatrists who like their office practices and don't want to be rubbing shoulders with those primary care doctors. I don't know what it is. They don't want to be embedded with the low lives. I don't know. Personally, I think it's wonderful to be embedded with them. And there's a whole lot of wisdom in a primary care doctor who's been doing this for 10 years, 15 years, 30 years. I don't know what direction it's going to go. There's been a lot of studying of it. In fact, one of my worries is that that integration actually happens, and I will no longer be able to see a patient and then send them to myself to do a psychiatric evaluation, because they'll have these stupid rules about, you know, so I now understand why consultants need a referral. It's only so they can bill more. In psychiatry, we never get to bill more anyway, so we don't have that problem. I'm sorry, I shouldn't talk about billing, but it's an incredible reality. I started there, had my training on the EMR. Okay, so this is how you do the notants, and then this is how you assign the ICD-9 code, and this is how you do your CPT code, and then you push that button and you just build it. I do? So yeah, we do all that ourselves.
Do you dictate or do you type?
Both.
Both.
We can dictate anything we want. I find it faster in the exam room to type while the patient is talking. Quick documentation, physical exam while the patient is talking. Document the plan as I review it. Okay, so we're going to do this for your diabetes, we're going to do this for your hypertension, we're going to do this, and then they remind me of what I forgot, or, you know. For psychiatry, I dictate the subjective. I do not type while I'm seeing the patient in psychiatry. My psychiatry patients they come in, they get vitals. That's how that guy with his hypotension was identified, other than the fact that he couldn't walk. Because he was too busy.
And he was gray.
And he was gray, which might be identified as kind of a problem. I'm not sure if the long building receptionist would notice that. but-
Nor do they do vitals.
Right. So anyway, I get a vital, and some of my psych patients go, why do I have to do vitals? But I can't tell you how many times it's good when they're on Effexor or Wellbutrin, you go and glance at their vitals and realize, yeah, we're okay, or, you know, you really need to see your PCP about this, or whatever. And on occasion, I have some social anxiety people where I push towards beta blockers who also have hypertension, and I just go ahead and start it. Some people have very high blood pressures, and I say, you've got to see your PCP, and I go ahead and I start them on an agent because I just know it's too high. But anyway, so my psych patients get their vitals, they wait in the exam room, I bring them across the hall, and we sit in a couple chairs, not too different from the long building. I ask them why they're there, and then I hear their story. So I dictate their subjective, because it's usually just way too long to type. And then I have a template for the mental status exam, point and click, and adding stuff as needed. And I have templates for the plan and the assessment, access, access assessment, which I do.
So for the building, since you're saying it's completely separate, then your ceiling is pretty much as a provider. What's the ceiling for this?
You know, I don't know yet. I don't know yet because my group always hires on salary, and they lose money on you at the beginning, and then they make money on you at later. It's generally a 2-year time period, and then they invite you to. Is that my phone? It is. I'm sorry. Then they invite you or not to become a partner, and my partnership has just sort of gotten delayed because they're busy with. There was a big windstorm, so they didn't have a meeting. Then the next month they had the meeting, and then we're renegotiating our professional services agreement. And so we just kind of haven't gotten there. So my compensation is going to be retro. But I don't know exactly yet what it's going to sort out to be. They offered me, based on 50%, what they do is they look at the MGMA, they take for first-time hires, or initial hires, 50% of the 50th percentile for that specialty from the MGMA. Sorry, MGMA. Medical Group Management Association. For